across the country.
Next, no, scene minus, scene minus. Yeah, okay, that's still a balloon. And scene plus, and this is the 2.5 balloon. In fact, although you are seeing it nicely here, it gave us a lot of anxiety. It wouldn't open till it is at 18 atmospheres. There was a very tight narrowing at that very point where you are still seeing some narrowing. But eventually, when we left it at 18, slowly it has expanded. Next one.
The good thing is the guide support has improved so much.
Yes, yes. In fact, when this 2.5 was on, we pushed this guide a little more inside, like it is sitting nicely. Yeah, next one. Then we again attempted with the OCT catheter. No, again it wouldn't go. So we had to once again, in fact, while trying to do that, the entire system came out,
Oh.
the wire and OCT, everything. Next one. Yeah. Okay. So this time what we did was we somehow could re-engage, recross it with the whisper, and by the side of it we put a, BMW wire, and then we attempted the stent. The stent also, actually we took a stent which is probably longer than required. It is a 3.0 into uh, 23 millimeters. It was not going with to my great happiness. So I said, wherever it is, let us inflate, because it has crossed that very tight calcified area. So now it has expanded. Then we put, of course, the second stent. Next
Dr.
one,
Sharath,
please.
Dr.
Yep.
Sharath, can I interrupt you?
Go ahead.
How about the support of a guideliner here at this stage with this acute bend? Did you think about guideliner?
Yeah, it would have been a good idea. It would
No,
have been a good
even
idea.
the wire, I would feel, Sharad, you should have got the wire in the big distal vessel.
Absolutely correct. I attempted it for several minutes. Somehow it wouldn't go. So I thought, anyway, I agree with you. This
No,
wire, had it gone into PLV to the long
it's-
post, it would have been a very good idea.
It's an extremely difficult case, Sharad. I wouldn't sort of skip a single step. So microcatheter, and then through that very strong support wire into the distality of right would have been great help. Let's see anyway. Huh?
Yeah. Next one. So here we have a reasonable. No. We put the second stent now while
Bent easily?
the wire is there, and this, of course, had gone fairly easily. All the trouble was due to that proximal, very critical lesion. Next view. Yeah, the stent has gone inside. It's pretty good. This second one is 3.0 into 18. Next one. Yeah, this is the result after this. She has already, we used a lot of contrast going by her body weight and serum creatinine. So now next one. Next one, we of course pulled out that balloon, and then we did the OCT. Okay, let us see the OCT now. Okay, can you show the OCT? So this OCT is done only post stent implantation. One moment. After this, what is that? Next one. Next view. Okay. Yeah, scene minus. Yeah, leave it like this. Can you show that? OCT is coming. Okay, so let us see from the beginning. The Abhinav, would you like to tell your findings on OCT? You don't have the mic? No, it's okay. So the stent has actually proximally landed in a very healthy area, as you can see here. There is not too much of a trauma at this point. No, wait. If you go to so fast, then it's go one at a time. Okay, wait. You're coming from distal to proximal, or huh? No, I would rather ask you to show it from the proximal. Who are the other people with you, Hiremat? Apart from you, who are the other people? Who are the panelists?
I think I see Manoj and Shashi.
Okay. Shashikant in Hyderabad, and which Manoj?
Manoj Chopra in Nasik.
Okay. Manoj, my friend. Okay.
Yeah.
Nasik.
Video band.
Yeah. So, okay, you can see here, this is the proximal part. Yeah, just keep going. Yeah, he has just entered the stented segment. Yeah, go slow. So here the stent implantation is good, and the in-lumen area is 8.25 millimeters square, which is very good, much more than what is really required for a vessel like this. 6 millimeters square is good enough, but here it is 8.25, and the stent struts are also well opposed. Can you go slowly, step by step?
You have post dilated or not yet?
Sorry?
Post dilatation of the stent is done already?
No, that part we have not done. What we have done so far is we, of course, when we took the balloon, the distal balloon, we pulled it a little inside after initial implantation at 12 and went up to 18, because with so much difficulty I wouldn't know whether I will be able to put another balloon. So once the balloon is there, so I went to nearly 22 atmospheres at the junction of the two stents, which covered most of the distal stent. So the stent appears to be expanded in most of the territory, which you are just going to see. Keep going distal, yes. There is a point where one could also see the overlapping of the two stents, and just below that overlapping, there is an area of under expansion. It can be seen on angiography also. There is a big branch which is coming, which can be seen. Yeah, there we come to the overlapping of the two stents. Yep, little more. Yeah, you can
Yes.
see that overlapping area. Agreed?
Yes.
Yeah.
Yes, and just after this is a branch. Yeah, that's the branch, and then there is a under expansion. One second. Yeah, here one can see a little prolapse of the tissue into the vessel lumen, and yeah, go further, and even a little under expansion also. Here one can see a little prolapse once again. Just go back one or two. Yeah, there at around 10 o'clock position, one can see the prolapse of the. Yeah, you can show that. Yeah, little above. Yeah, that's the thing. Okay, further. Yeah, this part is under expanded clearly. The area, lumen area is 5.32 centimeters. And in fact, on angiography also, I'll show you. Yeah, go further. Yeah. Go down. Yeah, here again, the expansion is pretty reasonable. While again, minimal lumen area has come back to 7.7, 7.9 or so. Only one small part it is under expanded, just below the overlapping area.
Somewhere behind that 20 mark on the horizontal scale,
yeah,
behind the stent around 6 o'clock to 9 o'clock, you see something.
Yes.
Yes. What is that?
I think that's a fibrocalcific area which
Yes.
needs further expansion. Here the lumen area is 5.15. Can you give that 3 balloon? So, can you show the next one? 310. Next one. Yeah. You can see here the under expansion. The branch has gone, and just below the branch is the under expansion of the stent. So, I would at this point say that probably this needs an expansion of this stent with a high pressure balloon.
In NC or just NC?
Sorry?
You take an OPN NC balloon or just a regular NC balloon?
No, this is a this is a regular NC balloon. This is a regular NC balloon. I think it will expand with that because we have not gone to show me that thing.
Dr. Sharad, I have a question.
Yep.
The question I have is that see this area here is 5.5 or 5.4 square millimeters. So compared to the proximal and distal segments, what percentage stenosis is there?
Yeah, I agree with you. This would not be positive if you do a treadmill test or FFR. I'm not saying that, but having put the stent, you would like to expand it to the best possible extent, because there is a correlation between that and.
Suppose you're not able to get the balloon down. Suppose you're not able to get the balloon down, and you have a residual of 15% up to 15-20%. It is acceptable.
Yeah, I agree with you. What about the other panelists? Would they like to expand this further, or want to leave it like that?
I think
100%.
I think balloon goes easily, then I think we should expand it and try to oppose it in better ways.
Yeah, normally we always.
What do you mean? Why are you saying balloon won't go? I mean, balloon has to go. I mean, if balloon doesn't go, you take a second wire, but balloon has to go. I think that particular area On one side you have an 8 plus, and distally you have 7 plus, and that area is 5 plus. So it has to be expanded.
Yep.
Yeah, I agree
So
with
I
you.
agree with you, because we have passed a stent through that.
Exactly.
So if the stent has gone, this balloon should go. Fluoro, please. Oh, in fact, it's okay. I think the positioning, we will go to the left lateral view. It will give us the best possible positioning. Can you go to left lateral? Bring the table this side. Yep. Yeah, Fluoro. Yep. So do a cine without injection. Yeah, I think that's good. You can see the overlapping of the two stents as well as the under expansion. What is your opinion, Hiramat?
Yeah, you have to be just inside the stent. You are going to dilate the entire length, isn't it?
No. I think if I just dilate this, then I'm good enough, because we have done high pressure dilatation with the balloon.
No, but you are done with a compliant balloon, stent balloon. It's never going to be same with NC balloon. And so why don't you just, anyway, you're with an NC balloon, dilate the whole length,
I agree with you, but you see the minimal lumen area is very good, and stent under expansion or under apposition is not there. This is the only area of concern, given this lady's frail status. I'll quickly, in fact, she consumed already a lot of contrast. Pressure came down from 180 to 130. There's a sizable hematoma also, unfortunately.
To me, there's a focal under expansion. So probably I would just go to that particular focal area and do the post dilatation.
Yeah. This is what I'm planning to do. That you can see here that under expanded. This is exactly where it should be. Fluoro, please. Yeah, you can see that it is exactly there. Yeah. Can you just inflate it, sister? Inflate it. Yeah. Go to 20. 20. Remove the fluoro. Hold it at 20. Yeah. Fluoro, please. Yeah. Go to 22. Yeah. That's enough. Yeah. Deflate. It has covered the entire. Go to LAO again.
The rest of the stent is well opposed.
Inside.
The rest of the stent is well opposed, well expanded also, except for this.
Yeah. See, yeah. Okay. I'll just leave it like that. There could be another dilatation little down.
Dr. Sharad, you have a small aneurysm there.
Yeah.
Are you worried when you go to these high pressures of 20 or 18 atmospheres?
No. We are inside the stent. No, already two stents are there. In fact, the point where the aneurysm is, there are two stents. One, this is unlikely to produce any trouble. Yeah, inflate it again. This is probably the last dilatation. 20. Just do a cine. Just 1 second. Do a cine. No, it's well inside the stent. Okay, go to 20. Yeah. Okay, deflate it. Yeah. Wait there. Okay, I think I will come out of this vessel.
It looks better.
Let us see. We have not done a proper angiography. Yeah, last angio. Do it. I think it's made a difference. Can you go back and show that? Sin minus. I minus. Yeah, plus. Okay, they freeze this and put it on the other turn. Yeah, you can see here some degree of residual. Next one. Next. No, sin minus. This is the one. Yeah, definitely there is a reduction of residual stenosis, Shashikant.
Yes, I agree.
Although it could be improved, but this is about very good. We took a 1-to-1 size balloon and went up to 22.
Yeah.
So that should be good enough.
I will accept this residual of whatever you have, maybe 10%, 20, 15%, and then probably a more dilatation probably would
So
need to.
we will come out of this RCA,
Yes.
and there's a sizable hematoma. So the and a long duration, and more than anything, her can you give me saline? She needs replacement of this sheath with an 8 French sheath because of this hematoma. I think this LED, I am afraid we have to do it another day.
I think so, with the creatinine so high.
Yeah, creatinine is high, already 116 ml of contrast is used. She can tomorrow land in some renal problem.
Better there.
Let me ask a question. If aneurysms are there, let us, you have already seen the aneurysm of LED. What is your opinion? You guys can tell. Give me a straight, a long wire.
One, you have to size the stent to the size of the adjacent vessel, not to the size of the aneurysm.
No, give me a long wire, because this is, come to AP view. No, you saw that aneurysm in LED, no?
I did see what I feel.
Can you show it again? Can you show it again?
We should size the stent as per the size of the distal vessel, and then dilate it as per the distal vessel. There could be a small segment where the stent is not opposed to the aneurysmal wall, but that's okay. The flow would be good, and probably later on it would thrombose. So it's not a major issue there. But if you have a lesion beyond the aneurysm, probably here you have a lesion.
That's what we were debating it. We thought we will do that today. Flora, please.
Can you freeze the image?
1 second. No. 1 second. Sorry. Just 1 second. Flora, please. We will show it to you. 1 second. Show that. Flora. Remove the mag. You should do it in the center. Okay, 1 second. Yeah. So just. You
want to take a sheath injection to see if you have any problem?
No, I wouldn't really expect it in this case, because in that case there would have been a huge fall of BP. It didn't occur. Yeah, sister, just put that 7 French sheath in this, quick.
8 French.
8 French, sorry, 8 French. Fluoro, please. Fluoro. Yep. Okay. Now the bleeding, what happened is I did the puncture myself. I must say probably be punctured more than once. We did puncture more than once, and the original puncture, the wire didn't go, so I had to re-puncture, and that from that side she was bleeding, and so somebody was pressing all the time throughout the last 1.5 hours. But now anyway, luckily, probably the heparin effect is also gone. We gave a second injection of heparin also. So now anyway, it looks very clean. There is no bleeding. We will check her ACT and then remove the sheath as early as possible. There's a small hematoma. So, can you show that thing? We will ask your opinion, because we are going to do this LED after a couple of days.
LED in epicranial.
Yeah, I'll just show you the best possible view. Yeah, the third one. Yes. Freeze it, Prabhakar, come here. So let me ask all three of you, what would be your strategy for this LED lesion? Yeah, keep it there.
My feeling is left main is definitely deceased. Of course, your imaging will tell us. But if I was to do this case just based on angio, I would bring the stent back to left main. In which case, I would finish the circumflex first.
Okay.
So can we also see the epicaudal view so that we see the circumflex? Okay. I would put 2 stents in LED, one to cover the aneurysmal area and one to cover the left main LED.
Yeah, this is the one you wanted to see. I agree with you. She may require 3 stents in that circumflex artery, because it's a long one, and given that little disease of the LM, 1 stent may not go there.
How about the ramus?
Ramus has got a very critical lesion. It's not a small vessel either. But I think you cannot do so much, with this. Yeah, run it freely. So, Dr. Hiremath, you were telling something, you were nicely talking about this. Complete that.
I think I would put 1 stent in the mid LED and 1 stent in the distal portion of the circumflex, and then go for the bifurcation left main with 2 stent strategy.
Two-stent strategy means
I
what
would
exactly?
definitely use a cutting balloon on the circumflex,
Okay.
and then then do a DK crush. The
Okay.
LED osseum is quite okay. So you do DK crush and then put one more stent and then do final case.
Okay. Scene plus. See here, would you like to put the stent across the aneurysm into the distal LED?
Yes, definitely, because there is a lesion immediately after the aneurysm. So freeze this.
Freeze this. Freeze. Yeah, that's probably a mild lesion, Hiremat. That
Absolutely mild
post
lesion there.
aneurysm lesion probably is very mild.
Probably when you
If
do
I
an OC.
suggest to you, we put a small baby stent just across that lesion, entering the mouth of the aneurysm,
Yes.
but backwards it covers the proximal. I agree with you. The left main stent part and circ everything I agree, but putting this stent into the aneurysm and beyond that, you will need a very big balloon to expand it to oppose to the aneurysm wall, and
No. Dr. Sharath, I have a comment here.
Hmm.
Very important point. The lesion distal to the aneurysmal segment doesn't appear to be very significant. I agree
That's
with
what
you
I said.
that we should end the stent just in the sac, the proximal part of the sac, aneurysmal sac there.
Yeah.
Even if your stent goes across the aneurysm and ends in the LED beyond the aneurysm, never expand the stent to the size of the aneurysmal wall.
It will not expand.
It will not expand. You should never try to expand, take a bigger balloon or expand. You should just leave it floating in that particular segment. The flow will get maintained. Very few of these segments get thrombosed, and very few of these vessels will occlude with the stent thrombosis, something like that. And that aneurysmal segment will overall collapse a little bit, and there will be thrombus formation there. So the aneurysmal sac will form a thrombus and it will close. But you will have a TIMI3 flow distally without any risk of stent thrombosis.
Well, do you have? Sorry, Hiremat, what did you say? Do you agree with him?
No. I would go across the aneurysm definitely, because it's a diseased artery. Even if angio shows that it is stopping at the aneurysm, I'm not sure whether we would be able to place our stent exactly there. So I would go across, not to worry, and I would anticoagulate for initial 3 or 6 months, the orally, post discharge also.
My question is, what size balloon you will take? Would you like the stent to be opposed completely to the wall of the aneurysm, or you wouldn't want to do that?
No. It will never happen that we get the aneurysm, the stent to oppose the aneurysm. It will not happen. So don't even attempt. So we do our best on the LED stent, try and get it to the maximum level. There's going to be some gap between the stent and the aneurysmal wall. That's why we anticoagulate.
Okay, in a woman like this, anticoagulation, I'm very concerned. She's at a very high risk of bleeds if you give her anticoagulation. I would rather, of course, you can go by the data of all these trials like redual PCI and say give only clopidogrel along with clopidogrel or XR along with anticoagulation. But it's a very risky business. What's wrong in just putting a short stent that opens into the aneurysm and then leave it? What's wrong in that? I did few cases like this. The stent, let it just enter. You see, there is a diagonal coming just by the side of, there's a septal. After the septal is a diagonal. At that point, if you put a 3 or 3.5 millimeter stent, of course, you're anyway going to use a 3.5 or 4 millimeter stent for the proximal and the LM that you can superimpose. But the putting this stent into the aneurysm and beyond that, I think it's inviting a lot of trouble.
No, Dr. There's no trouble. There is no trouble, actually. There's no trouble. We stent across the aneurysms without expanding the stent to the size of the aneurysm. We match the stent size to the distal vessel, oppose the distal stent properly. In the aneurysmal segment, you're never going to have an proper apposition. Proximal to the aneurysm, you're going to have again a proper apposition. That stented segment which is floating in the aneurysm will not give rise to any problem whatsoever. I'm very sure we've done so many such cases. Yes, probably I would do, if you're doing an OCT for the next procedure also, maybe we'll study the aneurysmal segment, beyond the aneurysmal segment, we should study that vessel there and then take a decision whether we should stent it beyond the aneurysm or stop it just at the mouth of
that's fine. If let us say, if your stent is not going to oppose to the aneurysm wall and your OCT shows no disease in the vessel beyond the aneurysm, then why do you want the stent to enter that?
Absolutely, you can end it there. I
Yeah.
agree. I think I agree with that particular thing.
That septal is coming just beyond that septal. If the stent ends, probably it will.
Maybe at the diagonal. Maybe at the diagonal. The vessel is tapering there. Maybe at the diagonal.
Yeah. At the mouth of, let us say, at the mouth of the diagonal, if the stent ends.
There are lots of concerns to the, especially the oncology practice, especially significant problem, because practically they cannot advise anything.
I think just beyond the septal, we can just finish the stent and leave that part distal to the aneurysm. And the other part, what Dr. MS was saying about the anticoagulation. Now, with the newer antiplatelet agents, should we really use the anticoagulation in aneurysmal vessels, or is a dual antiplatelet with one good ticagrelor or prasugrel? It's good enough, gives a protection.
No, you drop aspirin. Don't give aspirin.
Okay,
you just give
aspirin and the newer anticoagulant.
You give ticagrelor because she's underweight for prasugrel. So you give ticagrelor and the NOAC, and then you can give 110 twice a day.
Sister, stitch చేయండి, క్యాపిల్ పెట్టండి, అక్కడికి వెళ్ళాక తీయండి. But we'll know the ACT. Okay. Let me just say something. The studies showed that nobody used Axer or say ticagrelor. Most of the time, when anticoagulation with Novax is used, they only used clopidogrel. One study tried prasugrel, and that one had a very high incidence of bleeding. I think with some patients of this Apixaban trial, the last one, there were Axer patients, their patients on ticagrelor. So I would say that I'm not convinced that you need to give anticoagulation for this patient, because it will first of all, we don't have evidence that it will help, and if you put the stent and take care of this critical lesion, probably that aneurysm may actually reduce over course of time.
Because as Shashi is saying, the aneurysm will reduce after you put a stent there.
See, the radial force will come down on the vessel. The vessel wall collapses a little bit. Also, a little bit of thrombus also will form there, and the vessel would close. What is important is even if you have a floating strut in the aneurysmal segment, never oppose the stent to the vessel wall. We just let it float there. One or two stent struts floating in the aneurysmal segment does not do any result. Does not result in stent thrombosis. So we need to match it with the proximal vessel. We need to match it with the landing zone. But if one or two struts floating in the aneurysm is no deal at all. No problem at all.
Will not be one or two stents. Sorry, there will be a lot of area which will be floating in the aneurysm. See, if you do post-stent dilatation with high pressure to achieve complete expansion of the stent, to avoid under apposition, under expansion, the same rule should apply here also.
No. No, Doctor. The vessel wall is weak. We do not expand the stent to the size of the aneurysm. The one or two struts, maybe here you will have 3 struts floating in the aneurysm. It's still okay as long as you have the proximal stent well opposed, well expanded. Dr. Hiremath, you have any comments?
One can debate on this. Dr. Hiremath, what is your final opinion? How do you do that? You still stick to that?
No, my first opinion is final opinion. I would go across the aneurysm, because I feel that you cannot have isolated this thing. Once DES is available, we are all stenting long, and in this case also, I mean, you are taking care of her today, but I think after 6 months, after 1 year, she should still be okay. That portion immediately after aneurysm has to be covered.
So, let us say, what is your opinion of putting a covered stent? It will go straight across, no worry about whether the aneurysm is falling on it or not, etc., etc. A covered stent from proximal or proximal to the lesion to the distal. A lot of people use covered stents for aneurysms. In fact, because of this case, I checked it yesterday on the Google, and I find many.
Not for an aneurysm of this size. Not for an aneurysm of this size.
Exactly. This is too small to use a covered stent for the aneurysm. Secondly, it's a bare metal stent. So the chance of restenosis is high. and you lease two branches, the diagonal as well as the
That's
septal.
the big issue. The diagonal will close off.
Diagonal will close even with a regular stent. So definitely they will both go with a covered stent. So I think it's not a good idea to put a covered stent.
Yeah, I was always thinking that I would put a short stent which will just open proximal to the diagonal, maybe across that septal, and then that anxiety that the stent is not close, opposed to the aneurysm wall would not be there. However, one can debate it.
Dr. Sharath, I have one comment here.
Okay.
Lots of times you leave a stent struts in the left main when you do an ostial proximal LAD.
Yeah.
The stents are floating in the left main sometimes. You try to do a very precise ostial LAD stenting, and you end up with a small melon seed and the stent. So leaving those two struts in the left main has never resulted in any problem. I don't think so. Anybody would have had a stent thrombosis or anything there. The only issue
Shashikant, I disagree with you here. We used to do that in the past.
Hi. We can see you. Yeah, hi. Can you hear me?
Yep.
Yes, sir. We can hear you, sir. Yes.
Okay.
Shifted and after 1 hour removed. Can I speak?
Yes.
Your light is over or something? Some disturbance is coming.
Okay, Sharath, go ahead. Whatever you are telling us.
I forgot what I was telling. I was talking about we finished the covered stent business. We said, yes, putting it precisely at the LAD ostium, I think even Hiremath would disagree with that. Gone are the days when we said we'll put the stent exactly at the ostium and let only one stent come into the LMCA, because people know that will actually many times produce narrowing of the circumflex ostium and so on. Today, if ostial LAD is involved or ostial circ is involved, we almost always put the stent from LM into the branch, and then of course do a kissing balloon dilatation or whatever, depending on the anatomy, etc. So one of the reasons people started saying that you should put the stent to oppose into the LM is this, that there are concerns about stent struts hanging. Well, you may say sometimes we put a stent across a diagonal, but there also the ideal thing would be to do a kissing balloon dilatation. Leaving alone the stent struts hanging generally is not a good idea. Sometimes it happens that we cannot help it. In this case, if you put a stent from LAD proximal to beyond the aneurysm, some concern will be there. I agree with you. Today, the incidence of stent thrombosis has come down. There is pathologic evidence that some of the aneurysms actually fall on the stent struts. We have some pathology reports also where originally aneurysm is there, but after the stent is put over course of time, slowly the size comes down. With that data, you can say that probably it is okay to put a stent across it. And probably with these very aggressive antiplatelets, stent thrombus also is very less. Okay, then I think.
Sharath, whenever you bring her for left, I think you have a lot of work to do.
Yeah.
I mean, you are actually ignoring ramus, but it may be a big branch.
Correct.
Secondly, you probably need to predilate the D2, which is just at the aneurysm, because there is a critical lesion, and once you put a stent, you might completely lose the vessel. So it is safer to predilate with a small balloon, so that we don't lose it on table. And thirdly, I'm really surprised the surgeon was not keen on. This is a Muscat case for a surgeon.
Correct.
Good ventricle, good targets, and I'm surprised that the surgeon.
7 days she waited before the decision from CABG to PTCI is changed. The family was originally willing for CABG, but the surgeon was very reluctant. He gave them a very high risk, maybe because of her serum creatinine and her frail status.
Weight, correct.
Anyway, it gave us an opportunity to do a difficult case, and I'm sure we will do this LAD, and I'll let you know what has happened to it.
Mm-hmm. You can still do a hybrid, actually.
Sorry?
You can still do a hybrid. The surgeon can just graft the LAD, ramus.
Absolutely, you are very right. To make it very non-risky, he can just put a off-pump surgery of putting a single graft on that LAD. That will take care. Of course, circumflex will be left behind. Maybe that also he can do.
He can do, of course.
Yeah. But LED, if
He
does,
can
you know,
get the he can get the ramus also actually.
yeah, then it is a full surgery. It will take a long time. If you say a quick job is LED stent
No,
also.
no, time is not an issue. I think more complete revascularization is important. So you have done half job for him already,
Correct, correct.
and he will do the other half. So together, I think the risk is going to be low.
Yeah, hopefully. Let us
The
see if
targets are quite
your
good,
point is
actually.
well taken.
The
It's a
targets are
very
quite good, actually.
complicated LM repair and circ and LED diagonal. I'll try again with the surgeon whether he can do a limited or full revascularization for the left coronary. Thank you very much, all of you,
Thank you,
for
Dr. Sharat.
giving your valuable inputs on this case.
Sharat, I must say you took an extraordinary case in these COVID days. I thought for a little while this kind of cases are not coming to the cath lab. So it was very commendable that you could find such a case for life.
You know that, to tell you the truth, every day 3 or 4 patients of COVID are walking into the hospital with breathlessness, coming to cardiologist, and I'm very worried about myself, honestly.
Yes.
And my
Yeah.
juniors, they do a CT scan today morning. Also, one lady came. We put a stent to her in March, just before the lockdown, and she came with breathlessness. Initially in the ER, they thought it is a case of some restenosis or something. I said first rule out COVID, and bang, it is there, severe COVID disease on the CT scan. So today, actually, we are not getting coronary cases. The reason we chose this is because these are one of the few cases which is available to me. I mean, very simple case, there is no point. The
Yeah.
patient's number has drastically come down in Virinchi, and in Indo-US, we still get some patients because this is a old hospital. So I'm
In most of the
this case
hospitals,
we
that's
have
the
to
situation,
take.
Dr. Sharat.
We
In
have no
most of the
option.
hospitals, that's the situation.
But case is great. We would have loved to see the whole thing. When it was written to me at 6 to 8, I thought you were going to do the whole job
No,
in 2 hours.
you're absolutely correct. The unfortunate thing is, if you see the hematoma here, you will be very, very worried, and the contrast and the patient size. That's why, you have a camera, you can show it here.
No, no,
Can you show this?
we trust
We
your eyes.
understand.
Don't
We
worry.
understand. I think I would
No,
stop
it
at this
says
stage.
big hematoma, and in between, for a short period, she went into a hypotension. We had to give her a lot of fluids, etc. So yeah, you show it here.
No. Personally, I would stop at this stage because of the hematoma, because of the creatinine, because of the time,
Absolutely.
and the
And
frailty
the
of
weight
Yeah.
also.
a staged
weight.
procedure is better. A hybrid procedure also can be thought of at this stage.
Less than 50 kilos weight female patient is a really high risk patient, and
No,
over and above you
and
have
the
the
work on the left is going to be quite extensive,
yeah.
My own feeling is you'll end up with left main bifurcation and 2 stents there, and one in LAD and one more in circumflex. So you will need 4 stents on the left side, though you don't touch the ramus.
Let us see how it. I think I'll give her a good break from this procedure, and then see her again. By the time, if creat comes down to normal, I hope first of all it will not go up tomorrow morning.
Yeah.
So the music may start tomorrow morning itself.
So we would appreciate if you can send us the images of the left system whenever
Absolutely.
you do it.
Okay. Thank you very much, and bye bye to all of you.
Thank you.
Thanks to Abbott for sponsoring this interesting
Explain
case.
patient about the limitations of telemedicine, that it is not the complete.
Okay, I think it's over. Huh? No.
We can hear you, but you're done, right? I mean, you're not doing any other case or anything.
No. We are done. Thank you.
Okay.
Okay, Manoj, are you doing a case?
Sir,
Sorry?
Are you doing a case, Manoj?
Okay, Manus. Okay, thank you. Okay, you put, you can remove that camera. Huh?
hello.
Yes, Manoj. I thought you're doing a case. No.
No, I think Dr. Shashikant is going to give a talk now.
10 to 7. 8 o'clock you remove the sheet. Amma, ela unnaru? Bagunara? Okay. Manchidi, padukondi.
Okay, Shashi, you are giving a talk?
Yes, I am. I'm just sharing my slides with you all. Can you see my slides?
Yes.
Okay, thank you. Good evening, everyone. Dr. Mr. Shravan from Abbott had asked me to talk to us about some of the few topics which are of interest for everyone. So he said tips and tricks on STEMI, but I said it's too vast a topic, and I think we should focus on one particular thing and see if we can get the message down for everyone, with especially this vexing problem called no reflow, slow flow phenomenon, which happens quite often in our patients who have a STEMI. And for us, very, very important, prevention is better than cure is no more apt here than in any other situation. So we all are familiar that we have lots of patients coming to us with acute MI, and we have to take it as a primary PCI for most of our patients. Almost 98% of our patients will go for a primary PCI. 1 second, I'm going to minimize this. Okay, so we need to understand the concepts behind thrombolysis. Today we are doing a few thrombolysis after the COVID era started, but majority of the situations is a primary PCI, and sometimes we do see patients who have a pharmacoinvasive approach wherein they are given a pharmacological therapy in the periphery and they are shipped to our hospital for a primary PCI or a rescue PCI. What is important is that we keep to the timelines of the window period, very, very important, and we need to organize our transfers. If there's a delay in transfer, probably one need to thrombolize and then shift the patient. Today, we are loading patients with newer and antiplatelet agents. Ticagrelor we have prasugrel, or very powerful antiplatelet agents doing an extremely good job for us. In some situations, we also need to give a heparin, especially if there's a small delay in getting the patient to the cath lab. I would personally prefer to give these patients IV heparin in the ER as soon as we see a patient with ECG showing an ST elevation MI. Because by the time the patient reaches the cath lab, I often find that the TIMI flow has improved with this heparin injection what we have given there. We all are familiar that most of our patients are loaded with high dose statins, 80 milligram statin in the ER itself, and that definitely has reduced the no flow or slow flow phenomenon in our primary PCI patients. 2B3A blockers, I use them quite liberally intra-procedure, more as bolus dosages of eptifibatide or tirofiban, sometimes an abciximab, but they are mostly during intra-procedure depending on the thrombus burden and the anatomy what I see inside. I do consider a thrombosuction when needed. This is very, very important. I'm very often successful when I do a good thrombosuction, maybe 8 runs, 10 runs. There are situations where I've done 20 runs, aspirating almost about 500 ml of blood, but leading to a very good result, either just with the thrombosection or maybe just needing a gentle balloon dilatation, rarely needing a stent implantation in young patients who have come with large thrombus burden. I do thrombosection not very regularly, but when I see a large thrombus, I do a thrombosection and have rarely had a bad result with the thrombosuction. It is very important that we ensure a good TIMI flow and get a good myocardial blush in our post-stenting results after the primary PCI. Of course, today the stent is most of the situations are drug-eluting stents. Filters were tried for some time at one stage to get optimal result, and the answer is no today. There's no evidence-based data to tell us that filters are any way better than thrombosuction. Of course, lots of patients with this sort of a situation where they have large thrombus burden and who have an ectatic vessels, we do consider a long-term antithrombotic therapy, maybe 3 months or 6 months of anticoagulation. Today, we have the newer antiplatelet agents also, which can be given in optimizing our results of primary PCI. Why no reflow is important? It's very important because this is one case example which we had. And if you look at this RCA, which had a proximal tight critical lesion, but the flow at the initial stage was quite good, maybe TIMI 2, TIMI 3 flow. A small myocardial brush clade is also seen distally there. We did a pre-dilatation with a balloon, I think it's 2 into 0.5 into 12, and the flow decreased in the third shoot what we have there. We are not getting a good shoot. That's because we thought the vessel was heavily calcified. And IVUS run at this stage definitely showed that there was an attenuated plaque in the distal segment there. The last part of the IVUS run there, showing you that there's a significant attenuated plaque and a large arc there. And when you look at the TIMI flow there, you have absolutely no flow in this vessel which was stented, and subsequently we lost this patient. We lost this patient. The temporary pacing did not help. She went into bradycardia, hypotension, and it was a bad result. Cardiogenic shock, no inotropes. We even tried to go in with an IA intratic balloon pump, but she just crashed and we lost her in front of our eyes. So no reflow is inadequate myocardial perfusion without angiographic evidence of a mechanical vessel obstruction. This is the definition of no reflow, and most often the mechanisms are distal embolization, ischemia-related injury, reperfusion-related injury, including endothelial dysfunction, and of course, individual susceptibility also is there. If you look at the individual susceptibility, females, patients who have a chronic kidney disease, patients who have a uncontrolled diabetes, very high blood sugars, 400, 500 in the emergency room when they come with acute MI, and these patients have a high chances of having a no reflow phenomenon there. So uncontrolled diabetes, acute hyperglycemia, 400, 500, severe dyslipidemia, high inflammatory markers, the CRP is very high, inflammatory markers are very high, total count is very high, and of course an abrupt occlusion, lack of preconditioning again is a very important feature there. Lots of times it's an ischemia-related injury, the endothelial dysfunction, and the reperfusion related injury, which is responsible for this no flow phenomenon. Of course, a distal embolization is the main crux for us when we have a large thrombus there and we do a balloon dilatation, pre-dilatation or a post-dilatation. Most of this muck gets distally and the side branches and the distal vessel close down. So how do we diagnose no reflow? In the cath lab, it's by angiography. When you have a TIMI flow less than 2 or a TIMI flow less than 3 with a myocardial blush grade of less than 2, you could do a Doppler wire and see that there's a systolic retrograde flow or a diminished systolic antegrade flow, a rapid deceleration of the diastolic flow if you have a pressure wire there. But most of the often that's not necessary. If you look in the ECG, the ST segment resolution is less than 50% or less than 70% at 60 minutes or 90 minutes after PCI. And pre-discharge, if you look at the myocardial contrast specification, you have a myocardial contrast echo, you have a lucent area there, and on MRI, you have a lack of gadolinium enhancement during the first pass, as well as a lack of gadolinium enhancement within a necrotic region. Even the late gadolinic enhancement, hyperenhancement has a lucent area within the hyperenhancement zone there. So pre-discharge, looking at the MRI, in the ICCU, the ECG resolution, and in the cath lab with the angiography and the myocardial blush grade, one can diagnose no reflow. If you look at this very important figure, what we have here, the tissue perfusion is very, very important. The tissue myocardial perfusion or the myocardial blush grade is very, very important. And depending on the blush grade, the mortality is seen. In this beautiful article given by Gibson in Circulation 2000, we have clearly seen that when you have a blush of grade 3, the mortality is about 2%. But when you have with a drop in the grade, the blush grade of 2 or 1, the mortality is quite high, 4.4%, 5.1%. And when you have a blush of 0, minimal or no blush, the mortality is quite high, 6.2%. So it's just not enough to open the vessel, epicardial vessel, but it's equally important to comment on the myocardial perfusion or the myocardial blush grade. If you look at the prevalence of myocardial no reflow, if you have in this beautiful article given again, Nicole in the Journal of JACC in 2009, if you have 100 patients with STEMI treated with primary PCI, evaluation of post-procedural TIMI flow, you have 1 patient with the TIMI flow of 0 to 1 and 6 patients with the TIMI flow of TIMI 2, but 93% of the patients will have a TIMI flow 3. Are we happy with this result? The answer is no. When you look at the post-procedural myocardial blush grade, about 44% of these 93 patients will have a myocardial blush grade of 0 to 1, which is a very poor marker of a good tissue perfusion. And the long-term results, tissue healing, the left ventricular remodeling, and the scar formation is much different for patients who have a myocardial blush grade of 0 to 1 when compared to patients who have a myocardial blush grade of 3. Of these 93 patients, if you have 44 patients with a poor myocardial blush grade, 49 patients with TIMI 3 flow will have a blood grade of myocardial blush of 2 or 3. And if you have evaluation of the post-procedural ST segment resolution, about 14 patients will have an ST segment resolution of less than 70%. Again, significant. Even if you have angiographically a TIMI 3 flow, a myocardial blush grade of 2 or 3, about 14 patients will have a ST segment resolution less than 70%. And about 35 patients will have a TIMI 3 flow, myocardial blush grade of 2 or 3, and an ST segment resolution of more than 70%. saying if you have 100 patients, only of 35 patients will have a good angiographic result, good tissue perfusion, and a good ST segment resolution with a good uh, evidence that the infarct size is definitely less, the infarct remodeling is better, and the tissue perfusion is better. More myocardium is salvaged. Let's look at the no reflow. What are the portents of a poor prognosis? If you have a low ejection fraction, if you have an increased endostolic volume, increased end systolic volume, there's a fibrous scar and the thinning of the infarcted wall. These are the worsening of the left ventricular function. This is what it portends. It helps. It tells you that you're going to get a worse left ventricular function. The greater risk of clinical endpoints, there's an increased risk of cardiovascular events, reinfarction, hospitalization for heart failure, and the worst survival, there's an increased cardiac death, both immediately and at 30 days and 1 year death rate. So no reflow portends a poor prognosis, reduced LV function, more events, clinical events, and even a cardiac death. What are the predictors of no reflow? You have certain baseline demographics, we all are quite familiar. Certain mechanistic implications are very important. When you have a high neutrophil count, when you have a high CRP count, when you have a higher platelet reactivity. Look at the indicators of disease severity, which you have a large infarct size, high cardiac biomarkers, low baseline ejection fraction, Phillips class more than 2. If you have the angiographic criteria of an anterior MI with an LAD is involved, a thrombus with a cutoff pattern, abrupt cutoff of the vessel, when the thrombus burden is large, greater than 5 millimeters proximal to the occlusion, a floating thrombus, persistent diastasis, reference vessel diameter of more than 4, a thrombus length more than 3 times the reference vessel diameter, reduced TIMI flow grade, pre-PCI, very important, the pre-PCI TIMI flow grade is less. Again, it portends that probably there's going to be more higher chances of having a no reflow. If you know the predictors of no reflow, one could take precautions. One could take precautions to reduce the chances of no reflow by reducing the pre-dilatation to the smallest balloon possible, let's say 1.5 into 12, or avoiding a post-dilatation and thinking of a direct stenting. So the longer time to reperfusion, the longer the window period, the larger the thrombus burden, the higher the chances that you would going to see a no reflow. In this beautiful algorithm given in the JAC 2017, if you have a coronary no reflow, the prevention is the first important step. The short door to balloon time, optimal blood pressure, optimal blood sugar, high dose statins at the point of entry into the emergency room, prophylactic intracoronary dilators if possible. Some people give an intracoronary diltiazem or nicorandil just after pre-dilatation, so that you have a good flow there. And of course, thrombus aspiration if a large thrombus is present there. And the worst situation is when you have a no reflow, the consequences are there's an infarct expansion, ventricular arrhythmias quite often, VT, VF, cardiac arrest, early congestive heart failure, acute left ventricular failure on the table, even a bradyarrhythmia is also seen quite often, especially the patient, what I had shown, the patient had a severe bradycardia and we had a cardiac arrest on the table there. So we need to identify what are the embolic prone lesions. And if you look at the IVUS, you could have a large attenuated plaque. This patient had large attenuated plaque. We just wanted to study for this previous patient example, what I had shown, whether there was significant calcium in this vessel there. Would it prevent us from having a good stent expansion? That was the reason why, that was the purpose of doing an IVUS for this particular patient. And when we looked at the attenuated plaque, but we said it's all, we were looking more at the calcium and we did not bother about the attenuated plaque, and we went ahead and stented, and the patient had a complete no flow situation and we lost the patient there. I have no experience with radiofrequency IVUS or the near infrared spectroscopy, but today we have OCT as an important tool in our armamentarium to tell us which lesion is more likely to have a distal embolism, which lesion is more likely to have a slow flow, no reflow situation. So if you look at the predictors and outcome of no reflow post-primary PCI for ST elevation MI, in this beautiful article coming from Australia, in about 17% of the cases, we do see a no reflow. The range from 5% to almost 60% in a primary PCI. In various studies, the range is almost from 5% to 50% there. And no reflow occurred in about 25% of patients with STEMI patients undergoing in the study primary PCI, and was more likely with older age, high thrombus burden, and delayed presentation. No reflow was associated with a higher risk of death at 12 months of follow-up. So it's very important, the prognosis-wise, if you're going to have a no reflow on the table, your prognosis, your long-term prognosis is going to be quite guarded there. If you look at the pathogenesis, it's basically an occlusive thrombus forming on top of a ruptured plaque there. And when we do a primary PCI, we are going to do our aim is to improve the distal myocardial perfusion, but when we have a large thrombus, a soft plaque or an attenuated plaque, we're going to have problems with the distal flow. The distal microcirculatory dysfunction is going to set in because of platelet emboli, probably because of a higher inflammatory state there, a reperfusion injury, endothelial dysfunction, and distal embolism with atheroembolic material there, leading to a secondary microcirculatory dysfunction, leading to a slow flow situation there. So what are the options we have? If you have a large thrombus burden, probably I would do a thrombosection, a good number of runs probably with a good catheter. We have multiple catheters available there, probably an intracoronary or intravenous GP2 inhibitors. Sometimes an intracoronary lysis does help, intracoronary streptokinase. If we have given intracoronary urokinase, we give sometimes a TPA. Sometimes we give a 2B3 inhibitor bolus, abciximab, eptifibatide, or tirofiban bolus to get a better resolution of thrombus before we go ahead and stent the vessel there. And if you look at the stent itself, probably I would go for avoiding a predilatation or predilating the vessel with a 1.5 millimeter vessel or a 2 into 12 millimeter vessel. Do a minimal dilatation at very low pressure, and preferably do a direct stenting if possible. If you have a distal flow which is very, very easily seen, I would definitely avoid a post dilatation. This is one of the most important risk factors for a patient who is going to in whom you think. And there are certain risk factors for a stent, for a post-stent deployment and no reflow situation. M-Guard, we did use for a short time, but we are not using it anymore. Covered stent, I'm not sure that's the way to go. The chance of stent thrombosis are quite high. And patients whom you think there's going to be significant distal platelet emboli, probably 2B3 inhibitors. Distal pharmacology with intracoronary adenosine, nicorandil, nitroprusside, verapamil. Lots of pharmacological drugs are available. When you inject these drugs in the distal bed, it's very important that we put a microcatheter down into the distal bed, assess the distal bed, and then give these injections in the distal bed. You're going to get a significantly improved the TIMI flow count as well as the myocardial blush grading when you inject the same drug, the pharmacological drugs, in the distal bed. You could always try an intracoronary lysis, which definitely sometimes when you have very large thrombus burden, definitely bails you out of the situation there. What is more important, the bottom line is short ischemic time. Once the patient comes to the ER, shift him to the cath lab as fast as possible instead of waiting for a long time for the patients to make a decision, the finances, the insurance, and so on and so forth there. So distal embolization is the primary event which happens during primary PCI. And when they did the study in Fokema et al., the distal embolization occurred in 30 out of 450 patients, that is 6.7% of the patients after primary PCI with thrombus aspiration, 6.7% after thrombus aspiration, and about 6% of the patients after primary PCI without aspiration, without thrombus aspiration. So the timing of the first embolization. So if you look at the pie charts here, what you have, the aspiration group versus the no aspiration group, you have a significant increase in the events after the stent deployment in the patients who have had a no aspiration of the thrombus there. If you give an intracoronary abciximab and aspirate the thrombectomy in patients with large anterior myocardial infarction, this was the INFUSE AMI randomized trial in patients with large STEMI presenting early after symptom onset, undergoing primary PCI with bivalirudin anticoagulation. Infarct size at 30 days was significantly reduced by bolus intracoronary abciximab delivered to the infarct lesion site, but not by manual aspiration thrombectomy. So they did two arms in the study, one with thrombus aspiration, one with the intracoronary abciximab, and the arm with abciximab with aspiration did much better. This was an article published by Greg Stone and group in JAMA 2012. Similar is the result with intracoronary streptokinase. This was a study which was published in JACC, and in this study, it has been demonstrated that low-dose intracoronary streptokinase, 2.5 units, 250,000 units, given immediately after primary PCI, significantly limited the size of the infarct, improved the left ventricular volumes and the left ventricular function there. And the study again showed that in certain select situations, intracoronary streptokinase or intracoronary urokinase, as in this dissolution randomized trial, showing that a significant benefit could be seen there. Today, we are using less lytic drugs. We are using more the intravenous GP2B3 inhibitors. We are using a good dose of heparin, keeping the ACT quite high, 250 to 300. And this is the case where we had a significant thrombus in this vessel in the proximal RCA. We gave intracoronary eptifibatide, gave them a bolus, we gave them an infusion, and day 4 a check angiogram with low molecular heparin. Warfarin was added subsequently. Day 4 we thought a significant resolution of thrombus, and at 6 weeks with warfarin, patient was discharged with warfarin. When the patient brought the patient back for an angiogram to see if he needed a stenting there, the thrombus has completely disappeared. We had an extremely good flow there. Had we stented this vessel in the primary situation, if you look at the distal flow, it was quite good, TIMI3 flow. Probably we would have landed with a no flow or a slow flow phenomenon there, and we would have had a difficult time there. This was a young female patient who came with a thrombus in the proximal LAD there, and we did a intracoronary lysis with tenecteplase, and we had an extremely good result. A check angiogram 3 days later showed a significant benefit there. They were not willing for a primary PCI at this stage, and this patient was not willing for a primary PCI for the reasons of finances. So we said, why don't we give a small dose of tenecteplase intracoronary? We gave tenecteplase and put the patient on heparin and antiplatelet agents, and subsequently we found that the vessel had significantly cleared with a good flow. I agree the TIMI flow is not the best, but probably for a young person, having avoided a stent and a balloon probably would have been the better way. Thrombosuction does very good results for me. I really love to do a thrombosuction there. I do a good 8 or 10 runs sometimes, and I do aspirate a significant number of material here. We did a good thrombosuction. In this case, we had in those initial years, we put an M-guard stent, which was available with us. It was just available for a year or two, actually. It was not available throughout. Fortunately, if you look at the side branches were still patent here. That's the advantage of the M-guard stent that you have. What is important is the distal embolization and small distal vessel cutoff is quite frequent, and it is not benign. A small branch occlusion, a distal LAD occluded completely, gives you nightmares sometimes in the night because the patient has a persistent pain, persistent hypotension. ECG changes do not regress. The patient is very restless. Even a small vessel which is having a distal embolization behaves in a very, very erratic way. Very difficult to predict the outcomes here. It occurs in about 15% of the patients undergoing PCI for STEMI, associated with large infarct size, lower left ventricular ejection fraction, and increased long-term mortality. What I prefer would be, instead of giving the drug through the intracoronary, through the guiding catheter, it is less expensive, it is less selective, it's got systemic effects. What I would do is give her the drug intralesional with a clearway catheter. It's difficult to get it now, but probably the best way would be to put a microcatheter distally and use a thrombectomy device, put a microcatheter distally, and infuse your drugs, the pharmacological drugs, to improve the microcirculatory bed with intracoronary adenosine, sodium nitroprusside, or your eptifibatide or epsiximab. Give it in the distal vessel, and you would have a very good, better chances of avoiding a slow flow or a reflow phenomenon. Intracoronary adenosine again is a beautiful drug. This was an example in the canine model there. I still say that mechanical approaches to thrombus are very important for us. I use the export catheter quite frequently. And then in this infuse AMI trial, which was a negative trial, 452 patients with anterior STEMI, anticipated PCI was less than, window period was less than 5 hours. The TIMI flow was 0 to 2 flow in the proximal and mid LAD. Primary PCI was done with bivalirudin anticoagulation. They did a manual aspiration in one arm and no aspiration in one arm with intracoronary epsiximab, and they found the infarct size at 30 days, the TIMI flow, the blush, the anterior segment resolution. There was not much of a statistical difference between manual aspiration and no aspiration there. The TIMI count, the TIMI3 flow, the myocardial blush grade was almost comparable, was not statistically significant in this infuse AMI trial, which was a 452 patients studied in this trial. But if you look at this TAPAS single center trial, patients presenting with acute myocardial infarction within 12 hours after the onset of symptoms, primary aspiration with export catheter, 535 patients, conventional stenting, 536 patients. If you look at the myocardial blush grade as the primary endpoint and the TIMI3 flow as the secondary endpoint, significantly better blush score was seen in the aspiration group in the orange when compared to the control group, and significant ST segment resolution was seen at 60 minutes in the aspiration group and control to the control group. There was a significant 43% reduction in death and non-fatal MI in the aspiration group at 1 year. The TAPA study was a positive study telling us there was significant effect on the clinical events. When compared to the infuse AMI trial, it was not better. The TASTE trial was a much larger trial with 7,244 patients with STEMI undergoing primary PCI with randomly assigned to manual thrombus, aspiration plus PCI or PCI only, and they were included in the part of the SCAR registry. And what they found, there was no significant difference in the outcomes at 1 year. This was published in New England Journal of Medicine in 2014 there. So you have a mixture of data here with, when you do a meta-analysis of this aspiration thrombectomy to reduce the no-flow reflow phenomenon versus conventional primary PCI, ST segment resolution at 60 minutes was much better in the group where they did a thrombus aspiration and had a better TIMI blush grade 3 post PCI, a p-value of 0.0001. Both were improved. The TIMI blush grade and the TIMI flow were much better. The MACE also was much better, again with a significant p-value. All-cause mortality was also better with a relative risk reduction of 39% there. And a final infarct size was not much different. This was an article published in JACC in 2013, where they did not find a much different size in the final infarct size, but all-cause mortality, MACE, ST segment resolution, and the TIMI blush grade was much better with aspiration. We do see conflicting results, probably the differential aspiration catheters, different techniques of doing aspiration. The timing of even a few minutes will make a difference. Current devices show a significant aspiration material of 60%. There could be a trauma of devices also. There was in one study a higher incidence of a CNS embolization there, most important, and that was a negative study telling us that probably one should not use a thrombus aspiration there. I have one beautiful case for demonstration. An 80-year-old woman who was an ex-smoker, surprisingly, had a severe chest pain, came straight to the cath lab, and this was the vessel we had. This was the right coronary artery, and this is the left shoot what we had there. If you look at the left shoot, let me just go back to your. Sorry for that. Okay, that's the left shoot what we had, and the LAD was having a TIMI1 flow initially. Quite a pretty lesion, very tight lesion there. The first pre-dilatation after we put the wire with a 1.5 12 millimeter balloon, there was no flow phenomenon. The patient had an increase in chest pain, increase in ST segment elevation there, and even a drop in blood pressure. And is it a no flow, reflow, or a mechanical issue? We were not sure what to do. And in this situation, again, we give a long balloon dilatation with a 2 into 22 balloon or 2 into 24 balloon, stent balloon there. And again, the flow had not improved at all. Multiple passes with the inflations with the balloon again did not make a difference, and low pressure inflations. We were not sure whether we should stent this vessel. Probably a stage came where we thought we should put a microcatheter in the distal bed, and we gave the pharmacotherapy in the distal bed with adenosine, sodium nitroprusside, small doses, and the I think eptifibatide was given here. We found that the distal flow was quite good. The contrast was washing out very well, and we did give an injection with the microcatheter being pulled back during the injection of the contrast. And ultimately, we stented this vessel with a good TIMI flow. Although I accept the TIMI blush grade was not very good in this particular picture here, but we did get a good flow, and I think we did avoid the no flow situation. At one stage, we even thought we will not stent this vessel because the flow was very refractory to the no flow was very refractory. So for a patient with acute MI with no reflow, pharmacology, and pharmacology. Persist on the table, include vasodilators, consider 2B3A, infuse your drug in the distal bed. That's very, very important, probably through a microcatheter rather than giving it to the guiding catheter. Do not forget the coronary perfusion pressure. Keep the arterial pressure high. If necessary, put an intra-aortic balloon pump, give inotropes, bolus doses of noradrenaline, small 0.5 ml or 1 ml of noradrenaline, bolus doses to keep the blood pressure high up so that you increase the perfusion pressure. In patients for atherectomy, probably an upfront pharmacology. Keep the runs short for vein grafts, upfront pharmacology, and definitely I would consider a distal filter if appropriate for these patients. No reflow is quite common, is associated with poor outcomes. Prevention is the best cure for this particular thing. No treatment is effective for established no reflow. Probably you can improve the no reflow by a good pharmacology, remaining on the table and infusing in the distal bed. The ischemia time is very important. Thrombus burden is very important. The plaque components, an attenuated plaque or a highly soft plaque is very important. Predictors of no reflow phenomenon, they contribute to the no reflow. So one should predict which patients are at risk. In such patients, one could avoid a pre-dilatation, avoid a high pressure post-dilatation, and of course a pharmacotherapy with the systemic drugs as well as intracoronary drugs with minimal mechanical intervention may be the way to go. Thank you for your patient hearing.
Thank you, Dr. Shashi, for a very detailed and extensive talk. I think every step that Dr. Shashi mentioned looks simple, but it can contribute immensely to the patient patient benefit in long term. If you get a main vessel opened with a stent, and
I send so and so on so and so date to this patient, because
is there a lot of background noise? Can somebody close that? So if we end up putting a stent and a good flow in the main vessel, but poor flow in the microcirculation, I think we have done no good to the patient. So Dr. Shashi, if I could just comment your that 80-year-old lady anterior, there you had some forward flow. I think whenever there is a forward flow, best to give intracoronary with the guide catheter, GP blocker, because that sort of takes away some more clot which is around. If there is no flow, giving intracoronary is no good. But if there is a flow, as in your case you had, so once you have a flow, to lose flow, I think it's not very nice. Like your first case in right coronary, you lost flow despite there was an antegrade flow. It was something like a 99% lesion, and you lost flow. So there, I think a lot of pharmacology must go to preserve the flow, take away the clots with pharmacology. So I entirely agree on your couple of last slides that pharmacology, and pharmacology. Many of these patients have low blood pressure, and what you use intracoronary becomes important. So if you're giving dilators through the microcatheter into the distality of the occluded vessel, low pressure is going to be a clear worry. So here, generally I use nicorandil because it's less hypotensive compared to NTG as well as SNP. But I feel adenosine and SNP are very strong dilators. I think in my all no-flow situations, if there is a good blood pressure, these are the two things I always do. Secondly, whenever you have a right coronary giving you trouble, always have a temporary pacemaker, because that is the only way you can give lots of adenosine. So adenosine, SNP, yes, but if patient is hypotensive, I also use adrenaline. So the patient is hypotensive, my protocol is give nicorandil, adrenaline, nicorandil, adrenaline, like that I go on doing, so that you get a good flow. The other thing is filters. I think if you have a huge artery, like sometimes the right coronaries are sort of 4.5, 5 millimeter, even in the distality. The filter, just as it works in the vein graft, it works in the coronaries too. So I'm quite fond of using filters. There was one time when we had a vein graft occlusion where we put a filter, and nothing would work. I mean, we couldn't establish a flow. So on the filter, we put a balloon, got the guide catheter deep in, something like 6 centimeters inside, and aspirated through the guide catheter to get a good flow. So there are different things. One fails, and the other one must be used. So you must be ready with everything. I mean, as you said, distal embolization has to be prevented. Once it happens, just as in vein graft, if you get distal embolization, I think you are completely sunk, you know. So we should. The other thing which is not possible for us, but the laser is actually becoming a very important way to address the occluded vessel with thrombus. most of our Indian patients, they come with an MI, but they are already 6-8 hours old. And it's not just the occluded vessel, but the distality of the vessel is full of thrombus. So I think in India, late presentation makes this no flow, slow flow very important. Also, Dr. Milan Chug, I was with him on another webinar just now. They make a cut in the balloon and take the balloon just like a microcatheter into distality and inject from back end. But I think the over-the-wire balloons are no more available. At least I don't get it, so that becomes no option kind of thing. The important thing is, I think Shashi mentioned, is give heparin in the ER itself. A vessel which is probably totally occluded gets a little bit of flow, which helps a great deal in subsequent steps. So I think that is very important. Manoj, do you have any comments?
Yeah, I think the thrombus formation or a no flow phenomena in a cath lab is a bigger challenge. And I think you both shared the different type of things what we can do. But in spite of doing everything, many times we'll end up with that the flow is not established, and that becomes a really big challenge. I think the thrombus aspiration techniques and the drugs, I think intracoronary giving a thrombolytic drug, that is the one thing with a microcatheter or a distal in the coronary might help in such situations. And I have done many with a TPA or urokinase, 1 or 2 mg tenecteplase, and repeat it 3 times, and urokinase around 1000 unit and up to 5000 unit, you can give it in intracoronary. That also helps in establishing the reflow in such situations.
I think this particular lytics intracoronary, I think a lot of Indians have bigger experience than Westerners, because we are quite familiar with the lytics too. So I think our data, especially Dr. Prabhakar, he has plenty of cases where he used intracoronary lytics. So I think that should be an important way to go. Whenever you do lytics, whenever you give lytics, I think we are more worried about the intra-wall hematoma. So whatever pressure we use, the lytics given can produce a hematoma inside, and that's why we probably should use a lesser pressure. So it may be a good idea, if you have no flow at the end of balloon or whatever you have tried, don't put a stent. Call him back after 2 days and then see if a stent is placed. If you have put a stent and you had no flow earlier, don't try to expand the stent fully. Just about put a stent, let the flow go, and bring him back after 2 days to further expand the stent with an NC balloon. So this could be some of the options. They are a part of deferred stenting or a deferred post stretch to the stent. But these are all very important because you don't want to end up with no flow. So no flow is a disaster, and I think stay away from that.
Yeah.
All right. What is the next? Manoj, you have any comments to add to this, or we go?
I think yeah, I agree with you. Basically, thrombus is sometimes a very big disaster in the cath lab, and in spite of doing everything, we are not able to save patient. And you lose patient in a cath lab because of no flow or thrombus, than a dissection or perforation or other things, which are I think we are able to manage them, but sometimes thrombus is a big issue.
I think the blood pressure, systolic blood pressure, is also very important.
Very important.
Sometimes my fellows, they take anterior MI with a blood pressure of, say, 90, and they say there is a tachycardia, but we are supporting and he's okay. But that's not good enough. I think under all these circumstances, put a balloon pump, because balloon pump is not for the main vessel, it is for the microcirculation. So balloon pumps, the real utility is to preserve the microcirculation and not just good output and things like that. So be very liberal, especially in anterior MI. A balloon pump you must put.
I think it's very important, the point you made, Dr. Hemant, that intra-aortic balloon pump, keeping the blood pressure high, using the microcatheter into the distal bed, and if you have an initial TIMI flow, which is quite good, probably direct stenting. These are the ways to go and to avoid a no flow. The cases which I have shown, some we have lost, some we have salvaged, but most often today with the pharmacotherapy what we have, we can salvage most of our patients. Let me say almost 9 out of 10 patients are salvaged if you use a good pharmacotherapy, a good preparation. You anticipate the no flow, and do a good pre-procedure, take a pre-procedure steps by giving intracoronary 2b3 inhibitors or an ecorandil or an nitroprusside or a adenosine, and then when you do prepare the bed, your chances of no flow reflow are much less.
I think in Hyderabad, you get the patients early. I'm not saying anything that you do differently, but it's just that there are so many cath labs that it's very easy for a patient to reach the cath lab. There are some cities like that. Even in Ahmedabad, people get patients to the cath lab very early. I was talking to some of my friends. So the thrombus is fresh. So the aspiration works. So aspiration you must do in many of these cases. I have not had a single embolization during aspiration. And one of the ways to get the catheter deep into the ostium, the second thing is when you're aspirated, you must maintain negative all the way till the catheter comes out from the groin. If you go loose on your negative, you see so many times the thrombus is hanging at the tip of the aspiration catheter that gets out. So A is you deep your catheter and maintain negative throughout so that catheter doesn't slip out. So thank you, Dr. Shashi. That was really sort of enlightening us, having done so many 100 cases on STEMI. Your talk was still very different, and I learned a lot of new things from you. Thank you indeed.
Thank you.
So we move on to Dr. Manoj Chukla's presentation. He'll be talking to us on robotics. Many of you probably know that Manoj and Tejas Patel are the only two people who own very expensive jets, as we call it. And they're the only two in India who are currently using the robotics. Manoj used to visit from Nasik to Ruby Hall. So long journey, tough journey, but I'm very happy the way he has climbed to the top. And we would hear from him how robotics has helped him in his day-to-day practice. So if I was to give a talk on robotics, I would go through the literature. But here is somebody who has experienced the benefits of robotics. And let's see what he has to say. Manoj, over to you.
Thank you, Dr. Hiramat, for nice words. Basically, whenever we talk about a PCI procedure, it's a guide catheter, guide wire, and the stents. And we have innovations constrained to a limitation of implantable devices, stents, or hardware, whatever the wires, catheters, and the balloons we are using, there are a lot of improvements in that. But whenever we do a procedure, we think we have a radiation and orthopedic risk at the hands. And sometimes it's a precision millimeter or sub-millimeter movement. And there I think the robotics plays an important role. We all know about the robotics market. Initially, it was a general laparoscopic procedures, then surgical robo, orthopedic spine surgery. And we have a first robotic PCI system that is by Corindus American company. There was a first clinical trial that was a precise where they used it in 164 patients at 9 clinical sites, robotic assisted angioplasty. 97% had a clinical procedural success, 98% device technical success was there, and secondary endpoint 95% reduction in radiation exposure to primary operator. And this was the first clinical trial, and after that, many centers started doing the robotics. This is a now second generation robotic available. Basically, we talk about increased precision, improved workflow, and extended capability in the complex procedures. And basically, it's you can see the system here. There is a console where the cardiologist can sit, and there are 3 controls there, from where the guide catheter movement, guide wire movement, and the device movements, that's the balloons and stents, can be moved very easily. Where cardiologists can sit, the monitor is just across the you can see it, a big power vision monitor. And
Anuj, do you have a pointer which you can move on the screen, or?
okay, yeah. This is the monitor which is just in front of you, and you can see that the robotic arm is near the patient. And if you are doing a radial procedure or femoral procedure, accordingly you can adjust that. There is a big button which we can move the robotic arm, and there is a millimeter to centimeter movements can be done as per the catheter fixation. So basically, when we look at the manual PCI and robotic PCI, what I find that anatomy assessment is close because of ergonomic visualization. Then the wire movements retract and rotate, that function is there. That's why it becomes easy to navigate the vessels. Then measurement with a robotic assisted is very good, better than our manual eyeball estimate or the whatever the cath lab softwares are available. Stenting position 1 millimeter movements can be very well achieved. And most important, I think the catheter cath lab radiation exposure, fatigability, and orthopedic strain which is there. So that's what advantage is the most important. As I said, the wire movement, rotate on retract. There is a proprietary software by this company where when you retract the wire, you can rotate it, and what way while passing a wire, it gets into small vessels or it gets in a turn, you are not able to do it. But with this rotate on retract function, you are able to wire it easily, and it reduces the procedure time also and the success also. Initially, it was basically studied in a porcine model, and then it's applied in the patients. And now I think more than 5,000 cases done with this ROR method. As I talked about the precision, basically the measurement of a lesion or a measurement sizing of the stent becomes very important with this longitudinal measurement, what is available with the core path. And I find that when we try to measure the stent length, what we want to choose, it gives us a very correct length and diameter we can decide. And because of that, the longitudinal miss is reduced. And that one study was done in that they showed aesthetic LLR trial that 68% longitudinal miss was reduced with the core fat. Then, as I said about the precision, it's a sub-millimeter measurement. Then 1 millimeter positioning of the stents and the balloons. And most important is that the guide catheter and guide wire, once you position that, you can fix them so that the movements reduce with the respiration. And procedure automation with wiring is very important, and that gives us the precision. And because of the fixing of the guide catheter and guide wire, pushing the stent becomes very easier. In the longer stents, when you want to put, the guide catheter fixing is there so that you are able to push the stents very easily. In this, I have shown you the visual estimate and the core path estimate. We were thinking that it will be around 38-40 millimeter, and the 43 stent we were thinking of, but with measurement, we could select 28 millimeter stents, and we got the good results. Protection, I think that's the most important, because whenever we are working in a cath lab, there is a risk of brain tumors, risk of cataracts, carotid atherosclerosis is increased, vascular aging we are talking about, and orthopedic injuries. In a 21 years of practice, there's almost 60% incidence of spine issues, 42% incidence of spine problems is increased. Average rate is 2.3% in the general population, but with cardiologists working in a cath lab doing complex procedures, orthopedic problems are much more. And basically, radiation, we don't have to, radiation shields we don't have to use. You can sit and do the procedure. Ergonomic visualization is much better. You don't have to bend there, so that orthopedic injuries can be reduced. And as improved visualization, because of the ergonomic sitting and the monitor positioning. As we know that the staff position is important and the radiation becomes accordingly. The first cardiologist, second cardiologist, and the technicians, the radiation dose reduces from 18.6 micro SV to 0.543 micro SV. So basically, first and the second cardiologists are more exposed for the radiation, and the robotic assisted PCI really reduces the radiation. This was the trial where they showed that the robotic reduced the patient radiation also, because the contrast media required was less, wiring time and the fluoro time reduced, radiation dose because of that 17% reduction was there. And basically, as I said, when you are sitting, improved visualization, easy wiring, catheter manipulation, the procedures of type A, type B lesions can be done in a less time. Radial applications, I think most of the work is nowadays radial angioplasties, almost 95 to 98%. Many times we do a right radial or a left radial, then there is a much more strain because you are bending and trying to do the procedure. So there is a more of orthopedic strain, and you are not comfortable doing a left radial procedures. Here there was in complex PCI, there were 334 procedures, and they compared the complex PCI manual and robotic, and in that 91% was a technical success rate, 99% clinical success. So high complexity, also the robotic and the manual PCI robotic also does a good job. And as I said about the radiation exposure with right radial is more. Then the orthopedic strain, if there is more, left radial, we avoid it. Basically, a lot of bending and ortho radiation exposure increases. So for radial procedures, there is a lot of learning curve. Because of that, radiation is more. And when you are doing a robotic arm assisted angioplasty, I think timing you reducing, radial benefits are much more with the robotic precision, because it improves the sub-millimeter measurements, 1 millimeter accuracy. As the wire movement and the fluoro time goes down, the radiation goes down with the robotics. Basically, for physician, it's very important that the robotics facilitates the adoption of left radial, really helps to benefit the patients. When the right radial, we are not able to use it. And orthopedic problems goes down because you are sitting. And hospital, really it helps or not, I don't know cost wise, but 36,000 is a cassette cost what we require over the robotic arm. I'll just show you that. As you vascular robotic PCI and the peripheral, it's available. Neuro, I think next year they might be launching for the neuro interventions also. As we talk about the traditional PCI, I think the clinical outcomes, we are doing a lot of complex cases nowadays, and because of that, physician getting exposed to radiation, orthopedic problems, and radial adoption is slow because of the lot of radiation or learning curve is there. And as I said, that the precision increases with the robotic. You can use 2 wires, 2 balloons, and 2 stents at a time. There are 2 slots available in that. And the safety of physician really increases. And robotic differentiation, I think it enables the radial adoption. And as you start doing more and more cases, you are much confident and doing the type A, type B. And initially we started with the type A lesions, but now we are doing type B, type C both. And the future capabilities, I think the telestenting, which was done by Dr. Tejas Patel, he did around 2 cases at 30 kilometers from Ahmedabad, sitting in the temple, and his center, it was done nicely. And artificial intelligence is growing, and I think that is going to give us the much more applications in the future. Basically, device manipulations and the precision will increase. As robotic assisted procedure, I told you about automated wire techniques, scale to full auto navigation of wires and catheters is the possibility. The remote capabilities we talked about, and basically different algorithms to guide peri-procedure lesion assessment, treatment plan, device selection. I think we always talk about the planning of the procedure, complex procedures we want to discuss, what material. So those help we can get it from the prescriptive analytics. and that might help us in increasing the workflow. Or basically, proctor is sitting somewhere and your junior is doing the procedure, and that time you want to help them out. That possibility will increase with this. I'll show you some cases what we did. Basically, we have done around 150 robotic plastic cases, 125 data I'm showing you here. Initially, we started with the type A lesions. And as we moved on after 25 cases, we started doing type B, type C cases also. And that was a bifurcation lesion, long calcified lesions, and bifurcations. Left mains, we did one case, we did a left main also with a robotic. I can show you some video here. You can see a stent here. Our guide catheter has been fixed. Then we have passed the wire, which is that you can see the wire is there inside. This is a robotic arm which we can see. This is the wire. We are loading the stent over there.
Manoj, your mic you need to be close to mic, I think. We can't hear you properly.
Can you hear now? Yeah. This is the catheter and this is a Y connector. Wire is there inside. There is a turbo button in this robotic arm where once you put a catheter, the wires and the balloons or the stents can be moved with a turbo button from the distal tip of catheter to the tip of catheter. It can go into a few seconds. That reduces the time. There are once you load wire and the balloons, there are slots available which rotate the wire and balloons. So you need to close the robotic arm cassette. Yeah. So these are the three knobs where you can balloon and the stent can be moved forward and backward. There are the rotational movements for the guide catheter and the guide wires. That was the video showing you the robotic arm. This was a long stent robotic PCI. Basically, 65-year-old lady came with an infeval MI, ST not settled. Patient was in shock. He was a raised creatinine, and she was transferred to us. So in the night, we took her for the angioplasty because the patient had a failed thrombolysis. She was in persistent shock. We decided to do a angio. Angio showed a RCA proximal 100% occluded, and the left system was not showing anything. It was a RCA lesion. So you can see here RCA after wiring, you can see a long lesion from the proximal RCA to distal RCA, almost going to a 60 millimeter length. And as I saw the lesion after, we decided to use a robotics in this. And luckily, procedure went very well. Wiring 60 millimeter stent, as we can fix the guide catheter. The 60 millimeter stent positioning became very easy, and we could do a procedure in a very short time. And the last result, you can see that a very good result with the robotic assisted PCI. Second case is I think osteal lesions. It really helps to millimeter, sub-millimeter movements. We are able to do it with just one click, 1 millimeter back or forward. We can move the stent, and for osteal lesions, it becomes very important. This was a 65-year-old female, came with unstable angina, ECG, STT changes, and angio done showed a osteal LED lesion. And with the robotic arm, we did a placement of stent, balloon dilatation, and you can see that the placement of stent was perfect. And basically, while doing osteal lesions, when you are not using two wires, two balloons, or you just want to put it at ostium, by manually try to move forward, backward, and 2-3 injections we have to give with. Once you take one injection, you know that where to forward or backward movement 1 millimeter can be very well achieved with the robotics. And in such situation, it really helps. And the third case was again the 46-year-old female came with a chest pain, sweating since 3 hours, ST elevation in inferior lids, ST depression, V1, V2, and he was not thrombolized and directly came for a PAMI. So you can see that the mid-sega RCA was completely occluded. We wired, ballooned it, and around 33 millimeter stent was positioned and deployed, and we had a good result. So basically, in emergency situations also, we have used robotics in basically initially robotic arm, loading of the devices, preparation of the robotic arm took time. But once our team got used to it, in a short time we are loading the devices and preparing the robotic arm and trying to do it. So it's becoming easier for us. And now bifurcation lesions, left main, or you can see long stents, we are doing it easily. So procedure time, fluoro time got reduced over the period. Time pay, type B lesions, you can see procedure and fluoro time. Initially it was high, but afterwards it reduced, and sometimes it's better than the manual procedures also. So basically, contemporary robot-assisted PCI systems improve operator safety by reducing radiation exposure, can improve procedural quality and outcomes by offering better accuracy in stent selection, positioning, and delivery. I think it's a new device. It's going to take many things needs to be evaluated, and I think more and more players will come in, and more cases will start doing it. And once I think artificial intelligence improvements and more analytics comes into play, I think that will become a better assist device which will help us in reducing our orthopedic and the radiation problems. And we know that initially when we started laparoscopy, we always thought that why it's a manual is the best method, but nowadays everyone is doing a laparoscopic surgery and trying to do the minimal invasive surgery. The same way, I think PCI also will evolve, and robotic may play important role in doing angioplasties. Thank you very much.
Manoj, great talk. I think we all learned a lot, especially for me. It was quite shocking that the stent length can be reduced almost by 68%.
Yeah,
That means
that was a one paper. There, the longitudinal means basically measurement of the stent, and that gives you a better selection of stent.
yeah, but 68% is a huge reduction. That means
that was one paper, and it was a short number. I think we'll need a more data for that.
What about the support? Like sometimes the stent is not good. Are you able to hear me?
Yeah, I am able to hear.
I cannot see the, now I can see.
Yeah.
I mean, suppose your stent is not crossing so many times, we deep the guide, put guidezilla into the vessel. All this is possible with your robotics, or?
No, still basically guidezilla movement is we can do it, but I have not done that. Basically wire and balloon stents. So one thing what I said that the longer stents we get a better backup from the guide. Basically, once you put a guide and it's in a proper position and you fix the wire and the guide catheter, they will not move, and that gives a good support for passing the longer stents and give a good backup.
Mm-hmm. And if you have to do a kiss and all,
yeah, kiss we can do. Basically, I have done a bifurcations. There, the two wires, two balloons, we can place it and do a kissing balloon.
But then you have two sort of inroads to.
There are now at present there are only one inroad while moving the. Once you put a one guide wire and the guide balloon, then the second wire and the balloon you can put it in a second slot where they can be fixed, and then you can move other wire and the other balloon through same slot.
So currently in COVID era, you are at home and doing angioplasty from home, or?
No, I am doing not from the home, but will require two sets of the devices. So at present, going to a cath lab, but trying to be very careful and trying to do the work.
I know. That's why I was thinking whether you are doing from home. If it is possible, then you can do a.
Possible, I think. Commercially.
Then you can do a rubeole cases also from Nasik, and we can. So that even I don't have to go to the cath lab. You know?
I think with the Tejas did a first telestenting, and after that commercially they are looking for this approvals and everything. I think by the 1 year more, that possibility is there.
Yes, I'm very happy you're learning to Learning means initially learning and now probably perfected to fly such an expensive aircraft yourself. And I'm sure as you learn more, you can teach all of us so that we also save on time. Shashi, you want to have any questions for Manoj?
You have to unmute yourself. Shashi, you unmute him. Yeah. Yeah.
So beautiful presentation. I'm really impressed with your slides there. Two questions which I have is that one, can we integrate this with an OCT now, or it's really the stage is quite far
No,
away?
basically OCT and IVUS we are not able because there are rotators, so that that catheter gets damaged.
Okay.
So because the wires and balloons, that rotators are different, and for this OCT and IVUS catheter is different, so we need a different rotators. They are saying that by the end of this year they should be able to launch those new devices.
You know, sometimes manually we cannot access the side branch.
Right.
So you said that with a robo, it's much easier to access the side branch. So still there are some failures, or you?
Yeah. Go ahead.
So occasionally the robo also will fail to get into the side branch, or your success chance on the side branch is always there.
See, basically, as I said, retract, rotate on retract, ROR, that function which is there. And you can move the wire with this 180-degree angle or a 90-degree angle, and you can place that. And accordingly, what you see the side branch is suppose at an angle, that angle you can adjust and wire that easily. Many times what happens is that while you want to be in a main branch and the wire starts keep on going into a side branch because of the tip. So where you can do a rotation of the wire tip to 180-degree angle or the 360-degree angle, so that you are able to push the wire easily.
Calcified lesions, calcified vessels,
calcified, basically, if it is going to require a rota or anything, that can't be done. But this NC balloon, we used it and tried to put a stent, and it's good enough. And only again, the pushing a stent in a calcified lesion, it becomes easier to because the guide catheter is fixed.
But doesn't it back up? Doesn't it back out?
No, once it is fixed, so chances of backing it also, it gets sucked sometimes.
Oh, okay.
And yeah, it can back out also, but then you need to be have a look at the catheter, it's moving properly or what ways it's getting directed. But 80 to 90% the movement is reduced.
Okay.
So wish you a happy conversion from manual to robotics, and I'm sure you'll be star for all of us in India.
Yes,
is there anything, any plan for today, or we are about to end of the meeting? Shashi, I don't have a program with me.
I think it's the end of the meeting we are planning.
End of the meeting.
All right.
Thank you, Dr. Hiramat. It was very nice to be there with you, and we enjoyed the session, both Dr. Sharat Chandras as well as Dr. Manoj. And thank you for your encouraging words.
Thank you, Dr. Shashikant and Dr. Hiramat. It's always pleasure listening to you, hearing from you, and your blessings. Thank you very much.
Thank you all. Thank you all the participants, and Abbott especially, who took a lot of efforts to bring all of us together.
Yeah.
So wish everybody a success and a safe passage through the COVID days to a healthy future, and hopefully soon.
Thank Abbott for this initiative what they have taken.
Yeah.
Thank you, Shravan.
Okay, bye.
Bye. Thank you.